Morning, everyone. I know people are still joining the webinar, but I am going to go ahead and get some of the housekeeping work cleaned up and out of the way right now so we can go ahead and get started as quickly as possible because we only have an hour with everyone today. So this is the first in a series of webinars that APT Associates is sponsoring on the future of health systems. The idea for the webinar series is to talk about important topics in health systems and to try and bring a diversity of voices to really think through practical solutions and actionable activities that we can focus on in terms of our shared goal of strengthening health systems. So today is the first of this series, and the first topic that we are focusing on is primary healthcare as a long-term investment. So I'm joined today by three excellent and very accomplished speakers who are joining us from around the globe, as I hope many of the attendees are as well. I will briefly introduce them, but not give full justice to all of their many accomplishments. So first we have Dr. Shams Syed, who is Head of Policy and Partnerships for the WHO Special Program on Primary Healthcare at WHO headquarters. Until October 2022, he was a unit head of quality of care, where he oversaw a body of global work on quality of care, including WHO National Quality Policy and Strategy Initiative, WHO's technical work on quality in fragile, conflict-affected, and vulnerable settings, and the release of the WHO Quality Toolkit, a first-of-its-kind web-based resource. Next, we have Dr. Asaf Bitton, Executive Director of Ariadne Labs and Associate Professor of Medicine and Healthcare Policy at Harvard Medical School and Harvard T.H. Chan School of Public Health. He serves as a senior advisor at the Center for Medicare and Medicaid Innovation for the Comprehensive Primary Care Initiative and the Comprehensive Primary Care Plus, two broad multi-state, multi-player efforts that he helped design, which match payment reform to sustainable primary care transformation in over 3,000 practices in 26 states across the U.S. He's also a member of the Harvard Medical School Center for Primary Care, among many other accomplishments. Lastly, we have Dr. Kimberly Green, Global Director of Primary Healthcare at PATH, a program which includes teams focused on early childhood development, health systems, innovation and delivery, HIV and tuberculosis, maternal newborn child health and nutrition, non-communicable diseases, and sexual and reproductive health. Dr. Green has nearly 30 years experience in public health management, policy development, and research. So as I mentioned, we are hoping to focus today's discussion on actionable thoughts and advice for how countries, donors, and others can better orient their health systems towards primary health care for improved health outcomes. There will be time for Q&A at the end of the webinar, so please go ahead and enter questions into the chat as we get going. And just by way of introduction, I want to recognize that, especially in a post-COVID world, which continues to grapple with the impacts of climate change, the importance of strong and integrated health systems that function for diseases across the life cycle, promote equity, and support emergency response is more important than ever. However, there are enduring challenges to health systems, such as the ongoing siloing of disease programs, and the overall fragmentation within health systems, especially across the divides between public and private sectors, public health functions, and individual and curative care aspects of health systems, and from the local level to the national level. All of these different divides require attention to meet the promises of primary health care. The Astana Declaration in 2018 brought a renewed emphasis on primary health care and brought forth a consensus WHO operational framework, which brings conceptual clarity to the different terminologies that we have long struggled with in this space. Under this operational framework, universal health coverage and improved health outcomes remain the ultimate goal. Primary health care is the approach that we take to achieve that goal, and health system strengthening is the means by which we implement that approach. But what does that really look like in practice, and how can we translate this conceptual understanding into practical action? It's with these questions in mind that I'd like to turn to our speakers today. Recognizing that we've come a long way in developing the overall framework for PHC, and that the post-COVID world has only strengthened the urgency to focus on these issues, I want to start the discussion with a quick round to hear what each of our speakers are most excited about related to primary health care. Kimberly, maybe we can start with you.
So very much echoing what you've just described. So pre-COVID, there were very strong global and country commitments to primary healthcare, really affirming it as being the approach to achieve universal health coverage, such as the Astana Declaration. But despite that, despite the great language, the great commitments, really the investments were relatively inconsistent to assure the right level of coverage, access, and quality of care in a number of settings. And so then with COVID-19, with the rapid country-led adaptations, the learning, the innovation, but also really spotlighting and deepening substantial inequities and putting immense strain on primary healthcare and its workforce. Together, all of that and more has really led to a seismic shift in thinking related to primary healthcare and the global health landscape overall. And so this is where I am hopeful, and I'm really excited about some of the renewed energy around primary healthcare and really thinking about how to do things differently, thinking through new models of organizing services, ensuring that public health function is part of primary healthcare, so that community surveillance, contact tracing, and so forth happens. Better financing for primary healthcare, and stronger digital technology. So there's lots of great ideas, great innovations, and really together, if we're able to invest in those and make them available at a high level, we'll start to see reductions in some of those health inequities that I mentioned. And so the last thing I just want to say is this is not the first time that we've seen a reinvigoration of primary healthcare. So with the economic downturn in Asia, that led to really exciting shifts in primary healthcare investment in Indonesia and Thailand, which has led to them being global leaders in universal health coverage. Thanks, and back over to you.
Great. Asaf, what excites you about the current moment related to primary healthcare?
Well, both as a practicing primary care physician and as someone active in the US and global space on primary healthcare, it's still true what's been true for decades, which is that primary healthcare is the most equitable, inclusive, cost-effective, efficient investment that stakeholders can make in their health systems. And the evidence is abundant and the evidence is clear. And not just the evidence, but also the bright spots are clear. I mean, it used to be that we would have conversations about primary healthcare bright spots and maybe 3 or 5 of the same places might be mentioned. But I think over the last decade, and Dr. Green mentioned some of them, we've seen just a continued quiet surge in excellence in the provision of primary healthcare and the promotion of primary healthcare oriented systems around the world through a multiplicity of means, those that are mainly publicly financed and operated, those that are mixed public-private, those that are mostly private. The other opportunity that really, I think, bears mentioning, because, it's sometimes when we get together and we talk about primary healthcare with health systems folks, invariably someone says, "Oh, this is old wine in new bottles." I vociferously and respectfully disagree. There's something different that's happening here. There is in the aftermath of the Astana Declaration and with the amazing work that has gone on across both the multilateral and country stakeholder map led by WHO and the World Bank and other organizations, there's been a great convergence around what we mean by primary healthcare. We used to be stuck in these definitional wars, and the academics would say one thing, the private sector would say another, government would say a third. Nobody could agree on measures. There's still a cacophony, but there is a convergence. There is a sense that the primary healthcare measurement and MFI, the sort of the framework and the indices around the WHO's measurement cascade that was in touch with a lot of great work that was done over the last decade at the Primary Healthcare Performance Initiative with 30 plus country partners from all over the world. There's a sense that there's a convergent way to measure what primary healthcare is, what the provision of good primary healthcare is, how to understand good financing, governance, inputs, service delivery, core functions being met with and for communities, and outcomes to track. And so I think that with that convergence and the necessary contextual variation in its implementation, there's really a sense that we now have a common target map. Now we have a common language for talking about what good primary healthcare is and what we want to orient our investments in and around the UHC and the post-pandemic state that we're in. How do we orient investments to de-verticalize where we should and to connect verticals where we can, and to really make sure that primary healthcare is a central part of the health security and resilience discussion.
Great. And Shams, last but not least, what excites you about the current moment in primary healthcare?
Thank you very much, Kelly. And of course, really fully agree with the points that Kimberly and Asaf have put forward. What really excites me is this political commitment that now exists globally, but perhaps most importantly at the national level, for radical reorientation of health system towards primary healthcare. And that word radical should not be taken lightly. That's what people are talking about, and that's what the decision makers are actually agreeing on. So if that is the case, and this comes back to the point that Kelly, that you articulated very clearly, PHC being the approach, health systems being the means, and UHC and SDGs being the goals, then it does completely change the trajectory that countries will take. Recognizing that there's a lot of work, of course, decades of work that we build on. The other thing that excites me is actually the title of this webinar, long-term investment. It's not something that we're looking for a year, 2, 5, 10 even. We're talking about decades that will be required to achieve what we're really trying to achieve. And then the third thing that really excites me is the operational nature of these discussions. This isn't, as both Asaf and Kimberly have highlighted, this isn't looking backwards into the past where we've had concepts, but we perhaps did not have sharp teeth to take those concepts to the field. And that's what we actually have now. So this is a huge opportunity to utilize what we have, those interdependent levers of change, often things that get ignored, such as physical infrastructure, are the heart of primary healthcare reform, things that might be perhaps not prominently in thinking, which it should be, like health and care worker issues, and not just the standard issues, but getting underneath the weeds on the primary healthcare workforce are critical. And of course, and this comes with a personal bias, but the focus on quality of care as integral to creating trust in patients, in families, and in communities. These are the things that really excite me, Kelly.
Great. Well, I think there's definitely a lot to be excited about. I don't want to sort of be all fully Pollyanna-ish, but I do think we have the right group assembled here to delve into some of these operational issues as you described. Primary healthcare really is about a whole series of different interactions across a wide spectrum of actors, both in the health system, outside of the health system, public, private, oriented towards public health, oriented towards individual healthcare. And really, I think it is in those interactions that we will see success in achieving these very optimistic ideals that we've gotten to in the moment. But let's delve into some of these interactions and really think about what is needed. And maybe, Shams, you could start building on what you just said in your work in quality, sort of thinking through the tension or the interaction from a primary healthcare lens between public health functions, and individual healthcare.
Cool. Thanks, Kelly. So just maybe building on the point on quality of care, it's an obvious statement, but maybe starting with that. So a nurse that is detecting an unusual event is the same nurse that's often going to be vaccinating a child. So let's come back to those basic principles. And if we are able to do that, then it is at the primary care level that those events are detected. And it is at that primary care level that the response will take place. But if we're looking at that primary care level, can we, and this is where the beauty of the PHC approach comes in, link with the overall public health functions that a country or a subnational level or facility is looking at. So this linkage between public health functions and so for example, surveillance comes in very clearly with the clinical aspects of care that a nurse or another health and care worker is going to be taking forward. This is also where the interdependence of those levers that we were talking about comes in. So we know that in terms of physical infrastructure, that a vast percentage of health facilities do not have water and sanitation that they should have to deliver even basic care. Now, if that is the reality, how can we talk about quality of care without these foundations of water, sanitation, and hygiene or energy within a health facility? At the same time, if we are looking at UHC oriented reform processes, purchasing and payment systems are being designed for the future PHC oriented health services and health systems. Where does that PHC lens come into that? And perhaps another one, and these are the interdependencies, engagement of private sector providers. We know that a percentage of services and a significant percentage of services in many parts of the world, even in the most difficult parts of the world, are provided by the private sector. Bringing that quality of care lens into this can create a certain momentum of change. And it's a very practical momentum of change. It's not just policy and strategy, it's facility level change through improvement cycles linked up very carefully with system level interventions that are required. And one final point maybe to think through in terms of interactions of these public health functions with clinical care is the context of fragility, conflict, and vulnerability. So 2 billion of our fellow human beings live in these contexts. Where does that leave them? So this is where, of course, and it's a sad statement for the world today, but conflict is not decreasing and perhaps increasing. How does the PHC trajectory see this and adapt for it, Kelly?
Thank you. That is a rich reflection on all of these different interactions. But we recognize in the global health space that there's still funding that comes in different silos and across different funding streams. And Kimberly, I know your work really looks at how all of those different funding streams come together. And so I wonder if you might be able to build on any of Sham's comments with sort of that perspective in mind, and how do we speak to all of the different players within the global health space who are rightly focused on the specific outcomes that are of most interest to them, and really get them to focus on the primary healthcare outcomes that are of interest to all.
Kelly, yeah, as we think about what Shams articulated, this greater than ever before excitement, commitment, and financing from countries around the world now in primary healthcare, I think it's really important for us to look overall at alignment. So what countries are putting forth in terms of their overall plans, their goals, and where we can seek that greater alignment then with global health financing mechanisms. So these financing mechanisms like Gavi, like GFF, Global Fund, PEPFAR, and others, they have had tremendous impact. They have been phenomenal financing mechanisms. And because of them, we see significant reductions in mortality due to infectious diseases. We see reductions in under 5 deaths and maternal mortality, among many other improvements. And so while these mechanisms have been so effective, in many ways, we need to rethink how they're structured and how they finance and how they partner with countries. And there's a lot of different factors which are at play here. One of them is there really does need to be a new public health order, which the Africa CDC has called for, where these different financing streams are really able to first engage with countries around their plans and be flexible in how these resources are utilized so that they are further strengthening primary healthcare systems and services, community health workforce, where we see significant gaps. Overall workforce gap in Africa is substantial, with an 18 million shortfall of health workers globally. But then in Africa alone, we see about 4 billion financing gap in community health. So there are significant financing gaps that global financing streams, I think, could be, very effective partnerships in ensuring that there is that, in the shorter term, greater financing, partnering with countries so that we're able to accelerate coverage of primary health care and achieve some of those critical health outcomes and quality of care that Sham spoke to. But there's some underlying pieces that are really important. I think that as we think about the social determinants of health, and we think about gender, race, criminalizing laws, stigma, and poverty, I'd really like to see some of the global health financing platforms to be able to play a strong role in partnership with countries in supporting some of those global overall structural influences that affect the structural determinants to health. And I think there's a lot of challenges that we face right now in terms of access to sexual reproductive health. A lot of the criminalizing laws that we're seeing for LGBTIQA plus individuals with trans and gay phobia. So we're not going to get to health to all. We're not going to get to universal health coverage if there's not a way of working through some of these very important and very difficult issues that limit access to healthcare. And then I'd also just say that, there are other health diseases that have not been well invested in, and I would call on some of the global health financiers to invest in NCDs, which is where we see the significant burden and growing burden of disease. NCDs will account for 50% of global health disease burden by 2040. And there's also other infectious diseases that have been neglected, like viral hepatitis, which by 2040 will account to more deaths than HIV, TB, and malaria combined, as well as rising rates of STIs and a number of other diseases which are on the rise because of climate change. So what I'm encouraged by is that there's a really exciting effort, the Future of Global Health Initiatives. This is chaired by the Kenya and Norwegian governments, along with a number of other country leaders and global health financing mechanisms, to think through all of these questions around how to align resourcing requirements, targets, and to be good partners to countries, really enabling countries to call the shots in a much greater way. Thanks.
Great, thank you. I think we've talked a little bit about on sort of PHC from a country health systems perspective, from a global health systems perspective, but I think it's also, and you started to touch on this a little bit, Kim, important to think about just the community and the engagement of individuals and their role that they play. And I note there is a question in the chat, which I think goes to this, so I'm going to pose it and then let Asaf comment on the whole thing. It says, how do you see the role of social contracting in this context? Governments contracting health services out to community-based organizations. Are there pros and cons, cost savings? Could it play a role in PHC scale-up? So, Asaf, I wonder if you could sort of take that whole piece from the community level and talk about the interactions between communities and their health system in this broader PHC context, as well as the important role that advocacy plays, that health literacy plays. I know that's a lot, but take it where you want to go, and if there's any innovations that you've worked on at Ariadne Labs or in your domestic work that you think are applicable.
In 90 seconds or less. Well, this is one of the wonderfully radical and useful parts of a PHC approach, because a PHC approach forces us in medicine and health systems and sort of health care financing to demedicalize and really ask the question, where is health created? And the answer, of course, is that health is mostly created outside of the healthcare systems. It's created in and around, first of all, in people's interaction with a whole host of other non-health and non-medical sectors that actually the PHC approach in one of its 3 legs of the tripod really says that multi-sectoral action and policies are critical to optimize those. But the other critical non-clinical part of the PHC approach is really in codifying, elevating the importance of a community lens. So not it's a nice to have, or wouldn't it be cute or fuzzy or fun if we just listen to communities. It's a need to have. I mean, first of all, it has like face validity. You don't do things to people you effectively. You can do that ineffectively. You do them with. I mean, I had a mentor in medical school who once taught me that there's a difference between serving, helping, and fixing. When you say you're going to fix somebody or some group of people or some system, you implicitly assume that they are broken. When you say you're going to help, you assume that you're better and that they're in need of help or weak or something's wrong with them. When you say that you're going to serve them, what you're really orienting is an accompaniment function. We will walk with you through the travails and the challenges of making health achievable and equitable in this community. And that's what a community engagement perspective that PHC brings is so important, because communities have a more holistic view of what ails them, what is wrong in the community, than the medical practitioners or the policymakers or the private sector actors. They know their own needs. So it's an efficient play to go ask and work with communities and serve them side by side, as opposed to top down tell them what they need and how they should do. The pandemic, of course, brings up the issue of trust, but even before trust, there's traction. If you don't have a shared problem formulation of what you're dealing with, if the community does not believe what the health actors believe, that there is an epidemic or a pandemic virus that could be prevented with a vaccine, then forget trust. We don't even have the same problem we're trying to solve, let alone getting needles into arms. So then the question is, well, what prevents us from doing that? And I think that the way that we've seen systems all over the world, I'm thinking of Ghana in the CHIPS program, using Durbars, which are these monthly sort of codified, well-run, focused, village-level, nurse-led community health prioritization and community engagement sessions. I think of work that we've had the privilege to do in Costa Rica with EBAIS teams, doing the work of priority setting, engagement, going to visit every person's home, and deeply embedded in communities, not just hiding behind 4 walls of the clinic. I think of NCD programs that have been so successful in many parts of Mexico, especially southern Mexico, Kerala community engagement programs, NCD programs in Samoa. Go on and on. When you engage in the community, if there is an attention and attunement to the overall system priorities, to the measurement cascade. So engagement isn't just about sitting around talking about what the problems are, but really to the person in the chat's question, there are social contracting mechanisms in which you can, and I think we see all over the world the benefit of engaging in community-based organizations and contracting certain, whether they are social needs referrals, food, drinking water, violence prevention, etc., but also the question of how do you understand whether those referrals are met? So you can't just make a referral to some part of the clinical spectrum and then just sort of hope it's met, because often it's not. In the same way, you can't make a referral to kind of an engaged affiliate of a health producing entity in the community without using the same principles of referral management, data tracking, and understanding if those linkages were made and measured. So I think community engagement has enormous potential. It has enormous resonance around the world. It's why successful health systems are working in large part, but in the business of putting together these linkages and then acknowledging the truth that I would say maybe not most, but in many communities all over the world, private sector actors are the dominant force in primary healthcare, and so need to be contracted with, measured, paid for appropriately, tracked, just like they are in public sector. That's where things get complicated. Maybe we can talk about it more later.
Sure, yeah, I'm seeing a couple of questions in the chat, which I will take the liberty of trying to summarize in a bit of this chicken sort of egg kind of dilemma when we think about primary healthcare. We recognize how important primary healthcare is. We recognize these interactions. How do we sort of get from where we are to this end state that we're looking for? So there's a comment about community health workers being sort of a key linkage between the primary healthcare system and the community themselves. And that's obviously true, but we also know that there's a pay issue with community health workers. They're overburdened and unprofessionalized. And so there's that piece. And, you know, and so what comes first, the professionalization of community health workers or their, you know, increasing their role to help with PHC? There's also, as you were just talking about, the referral issue and the issue of whether or not we start with requiring referrals or requiring people to enter the system at the primary care level, even if, as Shem said, the infrastructure isn't quite there and there's a natural tendency to want to bypass that primary care level. How do we sort of drive people to primary health care? What do we come at it from both directions at the same time? Are there key opportunities that you see? I don't know if somebody wants to start with the sort of that set of topics.
Can I just weigh in specifically on community health workforce? So I feel like it's really important to reference the work of Community Health Impact Coalition. This is a phenomenal group of many community health workers and many allies of community health workers. And they are collecting data mapping where there are laws and policies that that remunerate community health workforce as part of the health system, where that exists, where that doesn't exist, where there's training, where there's not training. And I think the data and the clarity that they're bringing around the vast inequities and vast expectations that are put on community health workers is so important. And I think that as we think about, you know, our collective voices, wherever we sit, wherever we work, I think we can agree that community health workers are essential. There's no way we can achieve the health outcomes that need to be achieved without them. And so then really agreeing then on, you know, what are these important norms around fair remuneration and fair workload and safety, and also recognizing that the majority, 70% of community health workers are women, and the, you know, specific factors and inequities that they may confront in their day-to-day work. And so with all of that, at least for PATH, this is something we're very passionate about in allyship and advocacy around the community health workforce. But what I would say is that going back to that point that I made about more siloed financing streams, right? What happens in some countries is that there's different financing streams for different community health workers, and the government may not have a sense of who's out there doing what, for what project, for what donor. And just again, like a call for there to be more coordination and more investment from external donors in countries' plans for community health workers, and really investing in those rather than in separate, discrete workforce that may not be sustained over time. Thanks. It's a great question.
And Kelly, if I may just supplement just a couple of points, Kimberly's points on community health workers. One of the things that she highlighted is that this is thinking that through as part of a health system approach. So this is also a particular point of emphasis, perhaps, is when we're thinking about community health workers and thinking about overall planning for health and care workers, if we can bring that into the overall health policy and planning, that gives us traction at the highest level. And perhaps one of the things also to emphasize is that those policies and plans are often distant from the front line. And one of the things that the PHC approach also allows us to do is to take a very implementation-informed policy and strategy development. And this is again where the realities of service delivery should really be the primary injection into policy and strategy dialogue, which is often not the case. The other, maybe a quick point on the community side, is the importance of relational community engagement. So thinking about the science of human interaction, both in the geographical community, but also within the service and system. So the service and system is effectively equipped to receive the wisdom of geographical communities. So there are, of course, many ways to do that, but quite recently, some experiences in Asia, in Malaysia, Laos, and Cambodia have really thought this through in terms of how relationality can affect the health of populations, and particularly taking the lens of diseases, taking the lens of specific population groups like mothers and newborns, or a specific issue such as mental health. So really trying to bring in different entry points, but all with a PHC approach and all with that lens that Kimberly was describing. Kelly.
And I would just add to those comments, especially to the question of bypass. I think Shams, his comments orient to an approach to that. So, I strongly believe that if you take a relational approach, if you take a sort of from the user's perspective approach to bypass, the idea of just sort of making PHC a mandatory gatekeeper, it's a fool's errand at some level. If quality, both in a technical sense, in an accessible sense, so did I get the care that I need when I needed it? Was it done in a proficient, safe manner? And was it done respectfully to see me as a person within the context of my family, my community, my culture, my nation? If those aren't met, then PHC cannot be mandated to be a place where you just have to go through. It won't work that way. Now, that does require the medium to long-term approach. And I think that we can get into the fact that PHC is fundamentally a long-term play in an environment of multilateral and domestic investments that are looking for short-term wins highlights a massive incongruity. But there's no way around it, because all of those excellent PHC systems that we've all mentioned earlier did not happen overnight. There was no magic bullet of a quick investment, a quick win. Some of the best ones have taken up to 30, 40 years to really set in stone. And yet it doesn't mean that we should say that we'll wait 30 years. We can start now. There are some best bet levers and investment strategies, but we have to have an attunement to the idea that this doesn't happen overnight.
Okay, well, maybe building on that a little bit, because there is another question in the chat about political economy and the role of governance in this and the prioritization. So can you maybe give us a couple examples of those best bet opportunities that you just talked about, Asaf, and thinking about sort of how do we align incentives in this world where donors want short-term outcomes for their various constituencies, which are providing the funding to demonstrate that we're having impact. Political actors within a country might want to demonstrate that they're providing care for hospital-based care, those kinds of things. What can we do? What are the best bets to align the political incentives to really get action on primary health care?
I often wonder if it's important to think of sort of not just upstream, but sort of counterfactuals first. By that, I mean, if the first and sort of most obvious counterfactual is really asking policymakers really all over the world, every country included, is what you're investing in your health systems really working? Are you happy with what you're getting? And I think, save maybe 5 countries in the world, I would not say that they're all particularly very happy either with effectiveness, efficiency, equity, or sustainability of their investments. So if that's the case, then it sounds like something different needs to happen. It sounds like there's a consensus that we know we can chase verticals till the cows come home, proverbially. But there will always be another vertical after the vertical. There won't be the sustainable, effective financing mechanism for that vertical. We can't PEPFAR everything into being, though I think what PEPFAR has done has been incredible, but we can't make a PEPFAR for every important NCD and NTD that's out there. So then Where does that leave us? See, that changes the frame of the discussion, because the previous discussion, well, show me how primary healthcare is gonna do this, and show me that primary healthcare works. Well, it does, but show me that what you're doing right now is working. And I would argue it's not. So if it's not, then what's an alternative strategy? Well, the first place I would start there is to make visible what has been previously invisible. What is the state of your primary healthcare system? Do you know how mixed of a private and public system it is? Do you know what the data flows look like? Do you know what your workforce looks like? Who is the you? Are you the Minister of Finance? Are you the Minister of Health? Are you a private sector purchaser? Are you a community leader? From all of those angles becomes a visibility need. And that's getting back to the good thing, is that we have tools that start to allow us, with this convergent measurement and definitional approach, to basically say on one piece of paper, using the PHC MFI or other associated tools, this is the performance of your primary healthcare system, more or less. Now that you see the gaps, what would you like, in concert with a dialogue with your community and stakeholders, what would you like to look to improve? What are the financing, domestic or global mechanisms that are available for you to leverage an improvement orientation in these three areas? And if you have those three areas of improvement laid out, what are then the associated other 4 to 6 countries in your similar income and kind of contextual range that have tried, sometimes successfully, to mobilize this different input stream, that population health management approach, this governance change, or that financing facility? And that starts to get to kind of a smart sort of quality improvement, adaptive learning mechanism for improvement, and a way for kind of continuous engagement. So, hopefully we'll have a little time to kind of outline specific countries that have done that, but I think that that's the opportunity set now.
Great. Shams, maybe you can pick it up from there. And I also know there's a question for you in the chat about clarifying what you meant by relationality.
Sure. No, but if I may, maybe just a couple of additional points to the excellent points that Asaf made. If we're looking at the political economy, I think one of the ways of examining that are the 4 strategic levers that we are often focusing in on PHC. One is the political commitment side. The second is the focus purely on the governance side, which is, of course, a long-standing issue for health systems. The third is the financing side, and the fourth is the engagement side. These are, of course, interdependent. And if we look at each of those, then there is a very clear entry point for making the case for primary healthcare. And perhaps the most powerful of those, and this could be a bit controversial, is actually the engagement side, because that's where the people reside. And that's where the momentum can be created for PHC, even beyond the global noise around the subject. The actual citizen's voice, the person's voice, the people's voice is what can make PHC a reality in most countries. And that's where perhaps our focus may need to shift to. Traditionally, our focus has been on the political, the financial, and the governance arrangements, but really making that shift is maybe a point to emphasize. I see the question related to relationality. Demystifying this, all of us are interacting as human beings, right? So in this webinar, we are interacting in a specific way within a service or within a system. There are human relations which ultimately lead to that system functioning or not functioning. The idea here is, when we're talking about community engagement, to really focus in on those human level interactions, both within the services and at the primary care level, but also perhaps thinking about the subnational level. Imagine a district health management team that is taking forward the planning and delivery of services. How are they interacting, the human relationship between them and the facility level colleagues? How are they interacting with the national level decision makers? What's the relational dimension to that? So that's just specifying that a little bit further there, Kelly.
Great. Great, thanks. Maybe I'll bring in Kim. I know one of your areas of interest is behavior change in health systems. And I do think that speaks a little bit to the last question we have in the chat about social accountability and integration with PHC strengthening and these points that Shams was making about the interrelations and sort of the interactions between people and how people behave in health systems and how that relates to primary health care. Or something else if that's not what you want to answer.
That's a small topic. I'm sure I can cover it in a few minutes.
Sure.
There are some really wonderful examples where there's intentionality from the government and from the subnational local level to seek systematic feedback in a way that's very inclusive to assure that there is greater accountability. And so one of those countries is Thailand, and where there are community representatives who are not tokens. They play a substantial role in advising and providing feedback into how health services are delivered, providing feedback on how health insurance works. And we're critical for the COVID response. We're such a rapid and supportive community response to COVID because there already was that system established and in place. Asaf also spoke to the model in Ghana, which I really like. I lived and worked in Ghana for some years and participated in the Durbers, and they're amazing. It's a wonderful and very pointed opportunity for communities to speak their mind very clearly about what's working in the chip zones and what's not, and to, as a result, to tailor the healthcare system, tailor primary healthcare so it's not one size fits all, but it's really adapting to what specific localities need and want. And the other point that I'll make is that there are really important tools. There's a way of, using digital tools to more systematically, more rapidly collect feedback and to interface with government stakeholders. And so I think it's really important that they're not a standalone, but they can be supportive tools, technologies to have more rapid reach where there is that significant permeation of mobile phones and use of smartphones. And related to that, I think this effort to digitalize the digitalization of primary healthcare, making sure that really as much as possible, all of the data that's collected is available in a systematic way, because part of that accountability and that social engagement piece is that transparency also on performance. And I think that links back to the primary healthcare monitoring framework and indicators. So if the community isn't aware, doesn't know how their primary healthcare providers are performing, to Asaf's point, they go and maybe they have had disrespectful engagements, and maybe they didn't receive the drugs that they needed when they showed up, and they're not going to go back unless that's their only option. And so the data part is really critical and something that significantly needs strengthening. But there's some great models out there.
Great. Before we start to wrap up, because an hour has flown by, and I'm sure we could talk about this for a while, I wonder if there's any other key examples that any of our other panelists want to highlight or call attention to.
Kelly, if I may, of course, this time is going to be limited for that, but essentially there are various countries that are moving forward, but I think it's also important to look at subnational experiences. WHO has a very, strong focus on collating information from countries, but also subnational and facility level experiences. So one example to really highlight, and I think many colleagues will have been familiar with the work that's ongoing in Kenya, but the actual reorientation of health systems towards PHC is super strong in Kenya. And what's importantly and interesting to track there is a very strong focus on the measurement side, and focusing in on adapting the PHC MFI and all of the wonderful resources that Asaf was mentioning previously in examining how progress can be tracked at the most granular level, but also at the political level. So those are the types of experiences, and probably won't have enough time to go into the details, but in order for us to really move globally, we need to be able to get down to the granular level subnational experiences, which I think are being collated by many organizations, including WHO.
Thank you. Asaf, do you have any key examples you wanted to share?
Yeah, I mean, I think that when we mentioned this earlier, I'd like to just say it again. It's not the same old 5 countries that we can mention. There are really just this plethora of creative, substantive, community-oriented examples. I dropped a link to about 50 plus mini case studies that were collected through one endeavor, the WHO PHC website, and the material around the Astana meeting has a further 20 cases. The bottom line I would just say is this: there are detailed. They're not recipe books. They're compasses. They're directional ideas that can be adapted at national and subnational, local levels that are powerful. That can be applied to a variety and multitude of contexts. The other critical factor is to get specific. So to start with these principles of what PHC can be in its radical, equitable, improvement-oriented lens, and then get to specifics quickly through both measurement, through both bright spotting, and through really articulation, as all the panelists said, about what is the demand quotient here? What problems can we work together to serve, to solve, as opposed to another financing or governance scheme imposed on above? So that specificity, that idea that there are lots of ideas out there, and that crisp problem formulation, I think starts to get us into that next order solution finding for PHC innovators, of which I hope there are hundreds on the call today that feel oriented and activated to take these conversations from theory to action.
Great, thank you so much. I want to give each of this has been a really just fabulous discussion, very rich. Hopefully we can continue the conversation offline once this ends. We will definitely send out the recording of this session. But I want to give everyone, each of our panelists, one last opportunity to sort of a last word. We've really focused, I think, on the optimism that we have at this opportunity, the recognition that there are some key challenges that remain, but that there's examples and means to achieve those ends. And so maybe if we start back where we started at the beginning with the WHO operational framework that has 3 legs, and so conveniently we have 3 panelists. So I'll ask each of you to take one of those legs and just give us 1 or 2 sort of key actions that the people on this call should think about taking to take steps forward to really meet the moment on PHC. So maybe Kim, we'll start with you and take the service improvement leg of PHC.
Yeah. So the service piece under the primary healthcare definition includes not only routine services, right, but that public health function. And so, my call to action, and a lot of people are rallying behind this, is really, as we look at the high-level meetings in September, we have draft language for the Universal Health Coverage Declaration and the Pandemic Preparedness and Response Declaration. And I think it's so important that there is cross-referencing of language there around the critical role of primary health care in, of course, being the vehicle to assure essential health services for all, but also to strengthen response to health threats, not only to health threats that we know of now, but also really thinking about the growing threat of AMR and climate change and more. So really the demand and the ask of primary healthcare is more than it was before in terms of its potential role to be the early detector, the early responder, and really importantly, before any of that, to reassure or strengthen trust with communities, which we learned was a significant challenge in terms of the COVID response. So that would be my call to action. Thanks.
Great. Call to action from you, Asaf, related to how about engagement and empowerment?
Well, as was just mentioned, you know, we sit on the cusp of not just important meetings this fall, but really, you know, just a central drive across the world toward UHC. And the question that I hope people are asking is, beyond protection from catastrophic financial risk, what do we want to buy with UHC? And I would argue, and I think my colleagues here would argue, that we want to, in large part, buy, build, and partner around the creation of PHC-oriented systems. And so then the question of communities comes up, and instead of a kind of grab bag, oh, we should engage communities, oh, right, we should ask them some things. The hard part about taking lofty action and big buckets of money and governance structure and multilateral action and translating that into what happens next Tuesday in a community in a large peri-urban area of mostly poor people can actually be driven through a community engagement strategy. Ask people, communities, what they need, what their problem formulation is, what PHC services, approaches, etc. they would like to see, and use those to orient a bottom-up meeting of the top-down agenda. And that's not just a nice to have. It will orient a set of sustainable, tractable policies and service provision changes that will, I think, to earlier discussions, be that relational, that kind of approach to making tractable what has been intractable, which is, you know, systems that don't really serve people, that are inaccessible, too expensive, and just not, you know, on their priority list. When we ask communities, when we engage them in a multiplicity of ways, when they get surveyed, when they have participatory participation in governance and running the functions of PHC systems, magic happens and prioritization happens and sustainable change happens. And so that's the opportunity here to figure out that line of sight through the funds that will flow through UHC, that then will come to PHC, we hope, that will link up a network of often unlinked verticals, that will be an equitable and community-oriented approach to improving services and multi-sectoral action toward improving people's health, defined and in partnership with communities at all times.
Great. Shams, last word to you. Call to action on the multi-sectoriality element of PHC.
Yeah, thanks. I think one thing to emphasize particularly is just this interrelationship with those three arms of PHC. So really not thinking about the multisectorality by itself, but thinking it through as a linkage with the two other arms is important. But perhaps really thinking about this, the broader determinants of health, and recognizing that healthcare can only do so much in enhancing population health. We know that as a fact, but we perhaps don't recognize that when it comes to national health policy planning and implementation. One of the things, and this is very much building on Kimberly's and Asaf's points, is when we think about health in all policies, how do we think about the health in all policies? So let's just take an example of, say, food insecurity, which is an issue throughout the world, including the United States. Inner city neighborhoods, we know, are facing quite difficult food insecurity issues. How is that linked to primary care services? How is it linked to public health approaches? So making issues count and really thinking through those issues and linkages is my call to action. And maybe one thing to also emphasize is when we're talking about multisectorality and multisectoral policy and action, there is again a role of compassionate leadership within that decision-making process. So being aware of fellow human suffering and somehow empathizing with that and taking action to alleviate that. These are perhaps lofty principles, but if we can embed those principles into tangible policy level action, then multisectorality actually comes to life. Kelly.
Great, thank you so much. Another big thank you to the three panelists, as I mentioned, joining from all over the globe. So really, really appreciate your time on a Monday. As I mentioned at the beginning, APT Associates is hoping to do a series of webinars on the future of health systems. This was the first in the series. The next one, we are currently in the planning process, but look for information. It will likely be at the end of July, and we will focus on localization. So I think really helping us to bring this PHC and to think about, I really liked how Asaf framed it, serving, helping, and fixing, which I really think a lot of the drive towards localization is also about. And so we will pick up the conversation then and take on a new angle to it. And we hope to continue this conversation as well. So we will circulate the recording from today's session, as well as some of our key takeaway points. And we'd be really, really happy to continue the conversation as we go forward into these high-level meetings and just further conversations on PHC. But a big thank you to everyone for a great discussion. Bye-bye.
Bye.